access to social support groups. And with that, Dr. Zaafran is going to come up and get into the rest of it, which will be the next phase. And then after we're done with that, we'll do deliberation and discussion. And then we'll end with a final review, and then we will hear from Senator Cassidy, who should be coming soon. Thank you.
Great. Thank you, Vanilla. I really appreciate that. I just wanted to thank the members of our subcommittee that spent a lot of time talking and deliberating through this. I just wanted to give a quick shout out, though, to Cindy. I mean, I got to tell you that, you know, having a patient advocate and a patient herself on our subcommittee really grounds you to making sure that what's important at the end of the day, which is the patient, and the patient's perspective, is something that we always really have to pay a lot of attention to. We can come up with a tremendous amount of recommendations, but if it's not centered around what's important for patients and their perspective, then it doesn't really mean much. So having her in the committee really taught a lot of us quite a bit, and thank you for that, Cindy, so I really appreciate it. Again, thank you to Mac and to Molly. We spent a lot of countless hours together in the past couple of weeks finalizing this, and I think we've come up with an excellent product. So from the standpoint of the highlight of our recommendations, the first one was complementary, alternative, and integrative therapies. Not a lot of data on there, not a lot is quite understood, although anecdotally there's a lot of evidence that it works, not by itself, but in conjunction with a lot of other modalities. So from the standpoint of our gap, we looked at the fact that there's a large amount of complementary and alternative and integrative therapies that remains unknown in the management of pain, as well as a gap in the understanding of mechanism of action and how it applies to special populations. What works with who was one of the things that we really couldn't help identify. So from the standpoint of key recommendations, the highlights that we pulled out, considering complementary, alternative, and integrative therapies, including but not limited to, and we know that we're not all inclusive here, acupuncture, mindfulness meditation, art therapy, massage therapy, manipulative therapy, spirituality, yoga, and Tai Chi in the treatment of acute and chronic pain when indicated. Again, I know that this list is not all inclusive, but we try to at least highlight the ones that are very evident. Sound therapy, for example, we know that works a lot of times in the perioperative setting or even in labor and delivery, as well as many of the other modalities that we have listed out there. The other recommendation really centers back on trying to gather more evidence as to what works and why does it work. So conducting further research to determine therapeutic value, risks and benefits, mechanism of action, and economic contribution to the treatment of various pain settings, including the perioperative surgical pain period, along with various chronic pain conditions and syndromes. And finally, what's really important here is that none of this works unless you have a proper payment mechanism in place, which we've identified as a large gap. I mean, if you try to tell payers today to pay for sound therapy, they would just kind of stare at you. So from the standpoint of understanding that that is important as a component of multimodal, multidisciplinary therapy, our recommendation says that CMS and private payers should investigate and implement innovative payment models that recognize and reimburse holistic, integrated multimodal pain management, including but not limited to complementary, alternative, and integrative therapies. Next slide, please. Education. So public, patient, and physician and provider education is tremendously important in the management and treatment of acute and chronic pain. We've identified a lot of gaps from the standpoint of there being consistency, from the standpoint of there being continuing education, and from the standpoint of there being coordination and making sure that if we're asking folks to be educated on this, that it's done in a coordinated fashion. So again, these are the highlights of our recommendations. One is developing a national evidence-based pain awareness campaign that emphasizes the public's understanding of acute and chronic pain syndromes. And one of the important things about this is, you know, we talked a little bit earlier about stigma and destigmatizing the concept of acute and chronic pain. And the first way to start destigmatizing all of this is to make sure that the public is well educated as to what really is acute and chronic pain. Unless we do that, we're not going to really get anywhere. Convening a chronic pain expert panel that consisting of experienced patients, patient advocates, clinicians to develop a set of core competencies and other essential information specific to patient pain education. Again, this goes back to what I said earlier. Unless you have the patient involved in this process, it really doesn't mean anything. We can say a lot as to what we think is right, but unless you have that patient advocate, patient input into that process, it really doesn't make a lot of sense. Exploring intensive continuing pain education for primary care providers. I think we talked a little bit about that earlier, making sure that they are also up to date, since they are typically the first line of defense. This includes, but is not limited to, telehealth, telementoring, and the Project ECHO model, which we've seen works very well, as a means to provide pain education for primary care providers by pain specialists, especially in areas where, there may not be adequate access. Making sure that in those areas of inadequate access that there is a mechanism that folks who are out there in the front lines, again, treating patients, have access to that kind of information and education. And most importantly, at the end, is recognizing chronic pain as a category of diseases, that it's not something that is out there in isolation, that it has to be dealt with as a disease process, it has to be educated as a disease process, it has to be compensated for as a disease process. But looking at it as a category of diseases when the pain persists for more than the expected recovery time, approximately 3 to 6 months, despite appropriate treatment of the original inciting injury or disease. And the last one was probably one of the most difficult to try to put together because it encompasses quite a bit, which is the access to pain care. We essentially broke this down into several categories as far as what areas of access to care are important. We looked at medication shortages, insurance coverage, shortages in the workforce, and gaps in research as it impacts pain conditions. The first recommendation, which centers around medication shortages, one of the things that we've run into all the time is what do you do when you have a shortage of medications, especially one of the opioids. We ran into this several years ago when hydromorphone had to be used even more often because morphine was in short supply, or vice versa, and that creates a lot of difficulty. So what we ask is that the FDA should monitor, report, and prioritize the availability of key opioid and non-opioid medications, including injectables such as local anesthetics that can adversely affect patient pain care. We're running into this problem right now because of a lot of local anesthetics are simply in short supply or non-existent or in back order. From the second standpoint, insurance coverage, payers should reimburse pain management using a chronic disease management model. CMS and private payers should reimburse integrative, multidisciplinary pain care using a chronic disease management model in the manner that they currently reimburse things such as cardiac rehabilitation and diabetes chronic care management programs. It's got to be done in a horizontal fashion, not in a vertical fashion. It's got to be all of the above, not just one here and one there. Enhance the physician and other healthcare provider pain management specialty workforce, training and treating chronic pain with psychological comorbidities. This should include improved curriculum training in residency, fellowship, CME courses, and other continuing education modules that help improve patients' understandings and engagement in psychological treatment. And last but not least, increase federal and state funding through the NIH, DoD, and other agencies to support and accelerate basic science, translational and clinical research of pain, allocate funding to develop innovative therapies, and to build research capabilities for better clinical outcomes tracking and evidence gathering. And that is our report.
No. Sorry. So with that was a